Hi, everybody. Bob Davis. I'm a climatology professor in environmental sciences. I've actually been working on this topic, started in graduate school, where we were doing some of the first studies of climate and human health back in the 1980s. And for the last couple decades, I've been almost exclusively working in the area of human biometeorology, which is what we call this topic of how climate and weather affect human health. If we were to take a typical data set of mortality, like we have here for Philadelphia, and plot it against some climate factor, like here we have apparent temperature, the heat index, you get a blob of points that looks like this, and it's usually very discouraging looking if you're looking for a relationship. But it's there, it's actually hidden, and if you average the data across temperature, you get something that looks like a U shape, like we have here. As temperatures or the heat index gets higher, you see an increase in mortality here in Philadelphia, and it tends to be the case that you see the same thing as you get to the low end of the spectrum of temperatures. So, how unique is this? Is this interesting? Do we see this in other places? This study was done for 74 million deaths in 12 countries, 384 locations. Pick your favorite: Sydney, Australia, Sao Paulo, Beijing, Rome, Madrid, Seoul, Taipei. You see that this is a consistent relationship that we see almost worldwide. This kind of U or J-shaped relationship between some climate factor, some temperature-related factor, and mortality. And so that's kind of encouraging because a lot of things, as you know, in health are not necessarily very generalizable. So what we will tend to do, the community will tend to do, is we can identify statistically a temperature of minimum mortality. Now, this is nothing more than a statistical artifact. This is simply, for this particular plot, the heat index where the fewest people die. And then you can say, well, this might be useful because we can do comparisons as we move away from that. Now, as we move away from this sort of so-called optimum temperature, mortality increases. Now, I don't think a single person in this room would say that as the heat index goes from 82 to 83 that we're expecting a surge in deaths, or me whacking the microphone. That doesn't make logical sense. What we're looking for here is an edge effect. In general, by and large, on most days, most of the time, climate and weather have no impact on human health. This was the first thing I said in my first lecture last year when I was teaching my human biometeorology class. What we are looking for are edge effects, things that happen when we are at extremes. By and large, in the middle here, there's no statistically significant difference between an apparent temperature of 40 and an apparent temperature of 90. So this is part of the challenge in this particular problem. There are important effects that are happening rarely, and we need to understand those if we're going to really understand the problem. Now, what we could say is, well, I can make a projection now of how things are going to change in the future. I could say, well, as the climate gets warmer, we're going to have few of these and more of these. This is what I would call an oversimplistic, unscientific explanation of what's happening. I have seen this kind of thing published a number of times, and it always bothers me a little bit, but I understand the logic behind it. The problem is that it's a little bit more complicated than this, that we can see a point where deaths begin to increase above a threshold temperature, but these relationships of the low side are not necessarily related to low temperatures. In fact, on the coldest days, oftentimes there are less mortality than you have on a moderately cool day in the winter. It's not a simple linear relationship. This paper just came out a couple months ago by Maslow in Europe, where he looked at a lot of deaths over a number of different countries. And in the bluish tones are excess cold mortality. The reddish tones are excess heat mortality, as you can see, organized by country in Europe. Now, the first thing I notice is that, cold mortality, it doesn't seem to matter where you live, and it's pervasive, Northern Europe, Western Europe, Southern Europe, right? So it doesn't seem that there's a large geographic component. Heat mortality seems to be more concentrated in Southern Europe and less prominent in Northern Europe. Interesting. In the United States, it would be the opposite. We have more heat mortality in the Northeast and in the northern upper Midwest than we have in Phoenix or in Miami, right? So interesting that this is bringing in all kinds of other factors that go beyond simple geography. There's infrastructure factors, economic factors, et cetera, which makes this such a complicated and, in my view, interesting problem. Now, some research that I did, well, now it's a couple decades ago, where we looked at 28 different cities in the United States, and we looked at the trends in heat-related mortality and compared those to trends in the heat index. And when you plot them up on a simple plot, mortality trend versus temperature trend, you find that almost all the cities are in the bottom right. Interesting, right? If we were projecting increasing temperatures, we would expect most of the cities to fall up here in the top right, but they didn't. That's because, and this is actually good news, what we're finding is that despite increasing apparent temperatures, fewer people are actually dying over time. Great news. Why is that? A lot of reasons. We have adaptation. We have access to air conditioning. We have heat watch warning programs. All these things that are trying to prevent people from being up in this corner of the block and going down here to the bottom right. So I think this is kind of a cautionary message in the sense that projecting into the future based on your current conditions isn't necessarily the simplest thing to do. What we've seen here is what I would call strong adaptation, decreased mortality despite significantly increased heat index over the period of record for this particular study. So, this is my cautionary tale slide. These are all the reasons why this is hard, okay? And first of all, as I was mentioning, we're looking at rare events. We're looking at the extremes of the distribution. It's hard to predict extremes, right? But nevertheless, that's where we are. We're most interested in these rare events. The effect sizes tend to be small, relative risks of less than 5% or so, which means the error bars are large. So there's a lot of uncertainty just based on our current data, our current understanding of climate data and health data. The relationships between exposure and impacts are nonlinear and change over time. So if we're trying to project in 2040 or 2050, we're going to have different infrastructure, we're going to have different economy, we're going to have different policies, and all of these things can have an impact on health. How do we do that? Well, I'm not saying we shouldn't do it. I'm saying that it's very hard to do. Couple that with the error in climate model forecasts. Compared to the error we have in predicting, just understanding current health, the climate model forecast errors are small because this is a very difficult problem to wrap your fingers around. And both the predictors and the predictands have large error bars, and they grow over the forecast period of time. So this is our encouraging slide. It's going to take a lot of work of a lot of different individuals pulling together to try to reduce the error bars on these systems, but it's just an inherently very challenging problem. I just wanted to spend a few minutes talking about some things I've been doing in Virginia with some colleagues. We looked at emergency department visits both at Trillion, down in Roanoke, and here in Charlottesville. And on this particular plot, we're looking at some climate variable like temperature or the heat index over lag. The colors are showing us the relative risk of increased or decreased emergency department visits for that particular combination. So, for example, what we see here is at short lags, at both locations, the relative risk increases by about 5% on the day of the high heat or humidity event or the subsequent day. And these are statistically significant relationships. It's a small effect, but it is a persistent effect, right? My wife and I, Wendy Novikov, you're going to be hearing from a little bit later on, we worked on looking at heat waves and hospital admissions at the UVA Medical Center, and we found significant relationships in terms of total admissions for males, whites, and in particular is interesting for the age 20 to 49 or 50, which suggests that there is some kind of exposure effect. We're not seeing it in the elderly or the young, but people who are probably most likely being exposed in outdoors and can be greatly impacted. We looked at emergency department visits at Trillion in response to heat waves. These are odds ratios. You can see for the total increase of about 7% or so. We see it for males and females, whites and non-whites. The non-white is higher than the white rate. Different age groups, exertion, circulatory, respiratory, genitourinary effects also can be, pretty significant relationships. There are some good odd ratios. Now, the most recent study, one of the most recent studies we did was looking at a data set of every death in Virginia over a 17-year period. So a very authoritative data set. And when we looked at the overall pattern of climate for Virginia and all deaths, we found a significant cold effect, which you can see right here. And the way you would interpret a plot like this is say, okay, if the maximum temperature was -2 degrees on a given day, then if you compare that to the mean value, that the relative risk is about 1.1. So we can say when temperatures are less than -2, the risk of death increases by 10% on that day or over the next 21 days. So we have a lag factor that is incorporated into this. Now, the heat turned out to be slightly protective. This does not mean that there's no heat impacts on mortality in Virginia. It simply means that the cold impacts are significantly greater than the heat impacts. And we see the same thing as we saw in the plot from Europe, and we see this in a number of other cities and locations as well. Here we looked at diabetes and emergency department visits in Roanoke, and you can see the same kind of heat effect here. When temperatures are above, say, 15 degrees in terms of the minimum temperature, on that day, we see an increase in ED visits for diabetes. And finally, a paper that was just accepted a couple days ago. We were looking at renal and urinary ED visits to the University of Virginia, and here for this particular disease category, we see a significant heat effect, but not a cold effect. So we're doing a lot of different things, trying to really identify particular diseases and trying to understand exactly what's going on when you have heat and cold exposure. And I think by doing that, by sort of narrowing down our study focus, we're going to be able to make greater advances in terms of understanding the connections between climate and human health. And if you have any questions or comments and you can't track me down afterwards, I'm always happy for you to send me an email and I will get back to you. So thank you all very much.